Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Dear colleagues and PGs, from today we are going to start an interactive workshop on the management of hepatitis B. In this workshop, we shall discuss clinical scenarios and we shall see how to manage these cases under the guidance of clinical guidelines. And after finishing these clinical scenarios, then we shall discuss the lessons learned. We shall see the overview of these guidelines treating hepatitis B patients. So in today's session, we shall take the first case history and we'll see how to manage this patient with hepatitis B. Bismillah ar-Rahman ar-Rahim. Rabbi shrah li sadri wa yassir li amri wahlul uqdatam min lisani yafqahu qawli. So as I said, the topic of this interactive workshop is management of hepatitis B, and theme of this workshop is to translate guidelines into everyday clinical practice. We shall see how the guidelines advise and do recommendation in managing patients in everyday clinical practice. So today is the case history number 1, and it's a 42 years old female, and she presented with fever for 10 days, jaundice and vomiting for 8 days. Drug history was insignificant in this patient. On general physical examination, she was hemodynamically stable, and there was a tattoo mark on her left forearm. On systemic examination, she was jaundiced, and she was having tender hepatomegaly. On investigations, her hemoglobin was 11.1 gram, and this was on 16th March 2022. Platelets 1,63,000, WBC 4,500, bilirubin 9, ALT 1,134, AST 933, alkaline phosphatase 198. Her serum albumin was 3.8 gram per deciliter. Serum creatinine was 0.9 milligram per deciliter. Her INR was 1, and on abdominal ultrasound, it showed 4.5 centimeter liver span, and it was starry sky appearance. Splenic index was 35, and there was no ascites. Her HbS antigen was negative. Her anti-HCV, when done, it was negative as well. Her hepatitis A and hepatitis E, IgM antibodies, these were also negative. And the autoimmune profile and metabolic workup for liver disease were also negative. So she presented with acute hepatitis, but her virological profile, HbS antigen, anti-HCV, anti-HAV IgM, and anti-HEV IgM were negative, along with negative autoimmune profile and metabolic workup. So this is the case history. So the question comes, what should be next investigations of choice? There are 5 possible answers. And I will request you that you pick one answer and write it down. So when we proceed, we should know whether we need to be corrected or not. So the first possible answer is you check the HCV RNA PCR. Second answer is hepatitis B DNA PCR. Third answer is Possible answer, anti-hepatitis B core IgM antibodies. Another fourth answer is anti-HDV IgM, and E is HCV RNA PCR and anti-HBC IgM. So these are the 5 choices. I'll request you select one. You may select A, B, C, D, or E and write it down with you. Answer is HCV RNA PCR and anti-HBC IgM. This is the correct answer for this question. Why? Reason is, this is the profile of acute hepatitis B virus infection with recovery typical serological course. This is the HBs antigen, this is the titers, and this is the weeks after exposure. The HBs antigen appears around 4 weeks after the exposure. Titer rises to the maximum and then it goes down, and around 24 weeks it disappears. Then the anti-HBs appears after 6 to 8 weeks and it persists almost lifelong. Coming to the other antibodies, the total anti-HBC, it appears after the HBs antigen comes and it persists. Then the anti-HBC IgM, it appears and then it disappears when the anti-HBs appears. Coming to the E antigen and E antibody, initially it is HBe antigen and then anti-HBe, and the patient is symptomatic. The time when the HBs antigen becomes negative and still there's time to anti-HBs to appear, this is called window period. And in this case, the only positive marker will be IgM anti-HBC. This is the hepatitis C. When hepatitis C infection happens, symptoms may or may not be there, but the PCR appears, it's the first thing which appears, and roundabout in the second month, the anti-HCV appears and it stays almost lifelong. This is the PCR which appears, and if this is the acute hepatitis C and it recovers, so then the viral load goes down and can become negative within 6 months. So detection of HCV specific antibodies significantly lags behind detectable HCV RNA levels. The use of only an HCV antibody test to diagnose acute hepatitis C is not reliable, since only approximately 50 to 70% of patients have detectable HCV antibodies at the onset of symptom. So the correct answer is E, because one, the possibility is this patient's HBs antigen was negative, anti-HCV was negative, and the E and IgM were negative, the autoimmune profile was negative, metabolic profile was negative, but the patient presented with acute hepatitis. So possibility is either this patient is in the window period when there is no HBs antigen, but still the only positive will be the IgM anti-HBC, or it may be acute hepatitis C where antibodies is absent but PCR is positive. And that's the reason the correct answer in this patient is that you will do HCV RNA PCR to find out if this is acute hepatitis C, and anti-HBC IgM to find out if the patient is in the window period of acute hepatitis B. This is the HBV serological patterns. We shall discuss this in detail after we finish with these case histories. This is the serology, This is the HBV infection patient, and this is the immunity. In acute hepatitis B, HBs antigen is positive, and of course the anti-HBs will be negative. E antigen is positive, and then the anti-HBe is negative reciprocally. The total antibodies, core antibodies, and IgM both are positive. The PCR is positive, and DNA is elevated. But once this recovers, the past HBV, of course, the HBs antigen is negative, then the anti-HBs is positive, and the E antigen is negative, E antibody is positive, and of course, the total core antibodies is positive, IgM is negative, PCR is negative, and AAT is normal. So, and this is when it is vaccine. We will come to the serological patterns later on, but the point is that this patient, if this is acute hepatitis B, then this will be the typical serological test, that the IgM and the total is positive, and the PCR is positive, and of course the HBs antigen is positive. But this is when the patient is prior to the window period. So the case continues. So her investigations, anti-HBc IgM became positive, and when we did the PCR was 2,45,000, and her HCV RNA was not detected. So this patient, she was admitted and managed conservatively. Consultation from liver transplant team was sought. Her baselines were repeated on admission. And what were they? This is the investigation on 16th March. And this is investigation after a week. Hemoglobin 11.1 here and 11. Platelets, it was 1,63,000, and now on 22nd March, it was 1,83,000. WBC 4,500, 6,500. Bilirubin was 9, and now it is 11. The ALT was 1100, and now it is 930. AST has dropped from 933 to 640. Alkaline phosphatase, almost the same, 198 on 16th March and 180 on 22nd March. The albumin, almost the same, 3.4 and 3.8 and 3.4. The CRET is 0.9, and again it's 0.9. But the INR, it was a week ago, but now it has become 1.7. So it is raised to 1.7. So question is, how will you define this condition? What will you call this? Acute hepatitis? Option B, acute severe liver injury. Option C, acute liver failure. Option D, acute on chronic liver failure. And option E, subacute liver failure. So you pick your option and kindly write it down. If you consider this is acute hepatitis B, or you consider this is acute severe liver injury, or you consider this is acute liver failure, or ACLF, acute and chronic liver failure, or subacute liver failure. Answer is acute severe liver injury. And why I say this? This is the definition and clinical course of acute liver failure. So in hepatological practice, ALF is a highly specific and rare syndrome characterized by an acute deterioration of liver function without underlying chronic liver disease, as a case here. So severe acute liver injury, ALI, there is no underlying chronic liver disease. There is liver damage. The serum aminotransferase is more than 2 to 3 times. And there is impaired liver functions, jaundice, and coagulopathy. Up to 12 weeks post-jaundice, depending on subclassification, when there is hepatic encephalopathy, It's crucial for the diagnosis of ALF. Mental alterations may be initially subtle, but intensive screening for the first sign of the HE is mandatory. So when there is coagulopathy and liver damage, as in these patients, this is called acute severe liver injury. But when it is complicated by hepatic encephalopathy, then it is called ALF. So the ALF and acute severe liver injury, the difference between these two is that here there is no encephalopathy and here there is encephalopathy. In acute hepatitis, it is acute hepatitis, but when there's coagulopathy, PT-INR is more than 1.5, we call it acute severe liver injury. But when there is superadded encephalopathy, this is called acute liver failure. For acute and chronic liver failure, the patient must be having a chronic liver disease prior to development of this scenario. So, question comes, how will you manage this patient? Option A, start NA therapy, nucleoside analog therapy. B, you transfuse FFPs, fresh frozen plasmas. C, you start interferon therapy. D, you start immunoglobulin therapy. And E, you observe the patient with serial LFTs. So if you think you should start on NA therapy, write down your option A. If you want, you will transfuse FFPs, write down option B. If you think you should start interferon therapy, write down option C. If you want to start immunoglobulin therapy, write down option D. And if you want to observe the patient with serial LFTs, then you write down the option E. Okay? Correct answer is you start this patient on NA therapy, oral drugs, and the nukes. What the guideline says, it is a special patient groups, acute hepatitis B. So preventing the risk of acute or subacute liver failure is the main treatment goal here. Treating to improve quality of life and reducing risk of chronicity are also relevant treatment goals in such condition. So recommendation is more than 95% of adults with acute hepatitis B do not require specific treatment. It is required only in less than 5% of patients. Only patients with severe hepatitis B characterized by coagulopathy or protracted course should be treated with NAs and considered for liver transplant. These are the EASL guidelines. So characteristics of severe acute hepatitis B are coagulopathy. Most studies define this as an INR of 1.5 or more. R, protracted course means persistent symptoms are marked jaundice, bilirubin more than 10 milligram for 4 weeks. This is called protracted course, or signs of acute liver failure. So when this is the clinical condition, you start such patients on oral drugs. So what should be the drug of choice? You want to start the patient on oral drugs. What should be the drug of choice? A, entecavir. B, TDF. C, TAF. D, any of the above. Yeah, all of the above can be started. E, none of the above. Write down your option and see what's the drug of choice. Answer is all of the above. You can start either entecavir, TDF, or TAF. Any one of the above, you can start the patient on treatment. And why we say this? The guidance statement of the AASLD for treatment of patients with acute symptomatic hepatitis B is you can start entecavir, TDF, or TAF. All are the preferred antiviral drugs. So the guidelines say anyone can be started. So the question is, to decrease the risk of chronicity in acute severe hepatitis B, NA should be started with. It should be started within 2 weeks, 4 weeks, 8 weeks, 12 weeks, or 24 weeks. Answer is you start within 8 weeks, and this is the best time to start these patients within 8 weeks. Don't delay it longer. Earlier you start, better it is. And why we say this? Because there are two studies. One is the risk factors for long-term persistence of serum hepatitis B surface antigen following acute hepatitis B virus infection in Japanese patients. And what they found, that if the disease were started within 8 weeks, the chances of chronicity were reduced as compared to the one when it was started after 8 weeks. So observational data from a multi-center cohort even indicated reduced rates of chronicity if any treatment was initiated within 8 weeks of acute hepatitis B presentation in genotype A infected individuals. So another question comes, how long treatment should be continued? You started this patient on treatment, so how long you will continue? Till the HBV DNA becomes undetected? Option A. Option B, till the HBs antigen disappearance. Option C, for 4 weeks. Option D, for 12 weeks. And option E, for 16 weeks. You write down your choice. And let's see what's the correct answer. Correct answer is till the HBs antigen disappears. So you will, when you start a patient of acute severe hepatitis B on oral drugs, it should be continued, the guideline says, till the HBs antigen disappears. And what's the evidence? This is again from the AACLD. Treatment should be continued until HBs antigen clearance is confirmed or indefinitely in those who undergo liver transplant. But if this patient had to undergo liver transplant, then this will be lifelong. Pegylated interferon is contraindicated. For those diagnosed with chronic hepatitis B by failing to clear HBs antigen after 6 to 12 months, ongoing management should follow the guidelines for chronic hepatitis B. Once the 6 months period has passed, then of course, this is the scenario of the chronic hepatitis B. Again, this is our national guidelines as well, and it's saying the same, that the treatment should be antiviral treatment should be continued for at least 3 months after seroconversion to anti-HBs, or at least 12 months after the anti-HB antigen seroconversion. 4 days after starting on entecavir. You started this patient on entecavir. So 4 days after starting on entecavir, she developed renal dysfunction. Her creatinine was 2.1 and creatinine clearance dropped to 47 ml per minute. So the question is, how will you treat her? With entecavir, 0.5 milligram every 48 hours. With entecavir, 0.5 milligram every 72 hours. Or you will start the patient on TDF 300 milligram once a day, or TF 25 milligram once a day, or you can go both either the entecavir 0.5 milligram every 48 hours, or you start the patient on TAF 25 milligram OD. Write down your option. So the correct answer is either you give this patient entecavir, you reduce the frequency from daily to every 48 hours, or you start this patient on TAF 25 milligram once a day. And this is the reason why we say this, The recommended dosage of entecavir in patients with renal impairment. This is the guidelines that how you reduce this. And this is the, again, the TAFE is a good option for renal alteration, and you better to start these patients on then TAFE. So 5 days after starting TAFE, you started the lady on TAFE. So 5 days after starting TAFE 25 milligram once a day, she started complaining of altered sleep patterns, poor concentration, and on examination, she was having hysterexis. Question is, how will you modify antiviral therapy in this patient? Option A, stop antiviral therapy. This lady has developed hepatic encephalopathy, and you stop this antiviral in this patient. You continue same antiviral therapy. Option C, you decrease TAFE dose. Option D, you switch patient to tenofovir. Option E, you switch patient to lamivudine. So, which option you will go for? Write down with you either A, B, C, D, or E. Answer is you continue same antiviral therapy. And the reason is the guidelines, AACD guidelines again say the treatment should be continued until HBs antigen clearance is confirmed or indefinitely in those who undergo liver transplant. So developing hepatic encephalopathy, it's the acute liver failure, and it's not a contraindication to stop antiviral treatment. Interval between onset of jaundice and encephalopathy was 21 days. In this case, 21 days has passed. So in what category this patient falls, according to you? What do you think? She's a case of hyperacute fulminant hepatic failure. She's a case of acute fulminant hepatic failure. She's a case of subacute fulminant hepatic failure. All are same terminology or none of the above. So will you label this patient as a case of A, hyperacute fulminant hepatic failure, or just acute fulminant hepatic failure, or subacute fulminant hepatic failure? Or you think all these terminologies are the same? Or you think none of the above title is correct for this lady? Write down your option. And let's see what's the answer. Answer is she is a case of acute fulminant hepatic failure. Acute fulminant hepatic failure, option B. And why? We see this is the weeks from development of jaundice to development of hepatic encephalopathy. If the hepatic encephalopathy happens, this is the hyperacute, then acute, and then the subacute. In hyperacute, there is severity of coagulopathy because this lady was 21 days. So this is the reason it was in hyperacute, the acute. In hyperacute, there is severity of coagulopathy. The severity of jaundice is less, while the degree of intracranial hypertension is double plus. The chance of spontaneous recovery is good, and typical cause of the hyperacute patients presenting with hyperacute fulminant failure is the parastomol, hepatitis A, or hepatitis E. In acute, it's in between, while subacute, severity of coagulopathy is less, but severity of jaundice is more, and there may or may not be intracranial hypertension, and spontaneous recovery is poor, and these patients need liver transplant. Her conscious level deteriorated. She developed grade 3 encephalopathy with worsening of coagulopathy INR to 2.5 now. So the question is, What should be next best management step in this lady? A. Manage her conservatively. B. Stop antiviral therapy. C. Start immunoglobulin therapy. D. Refer to liver transplant center. And E. Transfuse FFPs. Write down your question. If you want that this patient should be managed conservatively, then your option should be A. If you want the antiviral therapy should be stopped, it should be B. If you want to start this lady on immunoglobulin therapy, your answer should be C. If you want refer to liver transplant center, your option is D. Or if you want to transfuse FFPs, your answer is E. Correct answer is now refer this lady to liver transplant center. This is the King's College criteria, and this was the non-acetaminophen case. So INR more than 6.5 with HE or any of the 3 of the 5 with HE, age less than 10 or more than 40 years, bilirubin more than 300, equivalents, the PTINR more than 3.5, duration of jaundice more than 7 days, etiology non-A and E are other drug. So in this patients, the PTINR went high, duration was more than 7 days of HE, and etiology was acute hepatitis B, and of course encephalopathy was there. So she fulfilled the criteria for the liver transplant. Remember, the King's College criteria remain the most clinically useful with sensitivity of 68 to 69% and specificity of 82 to 92%. So the take-home message in this case is the acute liver failure is a life-threatening condition with high mortality rate. Prompt diagnosis of acute hepatitis B and early start of NA therapy reduces chronicity risk and has better outcome. The NA therapy should be started within 8 weeks of acute severe liver injury. And of course, the dose adjustments or switching of NA therapy in the renal dysfunction is required, and consider earlier referral of patient to liver transplant center. So, dear colleagues, this was the first case history of our interactive workshop on management of hepatitis B with aim translating guidelines into everyday clinical practice. And I hope that we have learned all the important points and important challenges and the troubleshooting which such patients present to us. And we learned that how the guidelines advise us or guide us in the different aspects and at the different timings of the management of this case history. In the next video, we shall discuss the second case history, and similarly, we shall discuss every day one case history. And when we finishes the case histories, then we shall summarize and we shall see the overall the guidelines, how the guidelines help us in the management of hepatitis B patients in our day-to-day clinical practice. I request you that this is as the clinical material. Please feel free to share it with your colleagues and with your juniors because this is to improve the care of the hepatitis B patients. We know hepatitis B is one of the common liver etiologies or hepatitis cases in our country. And the good point is that the drugs are available which can very good with a good control of the hepatitis B virus proliferation and preventing these patients to develop or go into the liver cirrhosis. So I stop here. We meet tomorrow with the second case history. Till then, take care. Khuda Hafiz.